All right, everybody, we're going to get started. I appreciate all of your time today. It is a beautiful but chilly Thursday. My name is Catherine Carter, formerly Jackie Bowski. I'm joined with my co-chair, Adam Sansik. We will be doing our brief introduction of new visitors. If any of you have not attended this meeting before, we just like to have you stand up and say your name and organization. We like to give you a chance to do that. And you will have a separate time if you have any announcements related to your organization or work that you're doing later on. So do we have any new visitors? Adam will come around and give you a mic.
Hi there. Can you hear me? Okay. Hi, my name is Hannah. I am a patient support counselor with Planned Parenthood over on Burnham Avenue.
Hi guys, I'm Ava Ebbinghausen. I'm the Social Capital Coordinator over at the Rutland County Parent-Child Center.
Hi everybody, good afternoon. My name is Tim. I am a peer support specialist and recovery coach and training at the Turning Point Center of Rutland.
Hi, I'm Alyssa Scott. I'm the new Executive Director for Rutland County Health Partners.
I am Krista. I am also at Rutland County Health Partners, and I'm the Outreach Coordinator.
So a lot of you know me, but my name is Misha Phillips, and my new role is the SUD Street Outreach and Engagement Specialist with Rutland Mental Health, so I am now on the Street Outreach team.
Okay, wonderful. Thank you so much. And it's nice to see new faces always and so many friendly, familiar ones. We are joined with Chief Kilcullen today, so we'll have him start off some of his remarks and or announcements.
Thank you. So pulled up a little bit late today, and I noticed there weren't many parking spots left in the lot, so it's good to see everybody here today. Just a few announcements. So as you may know, the city, we structure the city, or we divide the city into 5 different sectors, and we have a sector sergeant responsible, has overall sort of operational responsibility for a sector. And then once or twice a year, we host community meetings in each of the sectors. So we last did this, I think in the spring, certainly last fall, may have done them in the spring. So we've got those scheduled again going forward. We've started to post those. They're on the city website, but I'll just give you a heads up. So December 3rd, those meetings will start, our sector meetings. So on December 3rd, we'll have we'll host our first community meeting for the Northeast sector, and that'll be at the Godnick Center. Again, December 3rd from 5 to 6:30. Also on the 3rd, right after that, our Southwest sector will have our sector meeting at the Rec Center. The city's rec center, again on the 3rd, that's from 6:30 to 8. And then on the 4th, our southeast sector, which will be at the Comfort Inn, that's on the 4th, again at 6:30 to 8. And then on the 5th, our downtown sector, from 6:30 to 8, that'll be at the Hub. And then on the 9th, our northwest sector, from 6 to 7:30 at the neighborhood church, 71 William Street. So again, it gives those that have some, whether they live in the sector, have businesses in the sector, or just have some interest in what's going on in a particular sector, to come out, kind of hear what's going on, and then ask questions and bring any concerns to us. Get to meet the sergeants who are responsible for that particular sector, and a number of other officers and members of the department. So we're also hoping to maybe get out some other departments from the city too, to talk about what they've got going on. So trying to sort of expand this beyond just the police department, so it'll give our residents an opportunity to really kind of learn more about what's going on sort of citywide, not just with the police department. Another sort of important meeting coming up December 10th at 5:30 is the Public Safety Committee meeting for the budget. So the budget process is, the department heads submit budgets to the mayor, essentially a request for funding for the department for the upcoming year, which begins July 1st of 26. So that's been submitted to the mayor. The mayor makes some tweaks and sends it off to the board. And then the respective committees then hold meetings to discuss that request. And so the Public Safety Committee will hear the police department's budget request and the fire department budget's request on December 10th at 5:30 at City Hall. Just so you know, I talk pretty regularly here about what our staffing looks like and what we can do as a result, what we can't do because of our limitations sometimes, but our numbers have really improved over the last few years. Real shout out to our recruitment team. You may have seen some of what they've done. They've done a really good job targeting individuals, targeting groups anyway, through working with some media companies. And so we've had some real success getting our numbers back up. We've increased our numbers by roughly 10 over the last couple of years. So we've been able to kind of maintain a presence that people ask for, do more traffic enforcement. Believe it or not, people ask for us to do more traffic enforcement. Usually not the ones getting tickets that are asking for that, but other people are. So we're able to kind of be more visible, be a little more active, and at the same time have not be so stressed at work, because our officers, when we're short-staffed, they're pretty much generally nonstop for 12 hours when they're there for a good part of the day. So we're glad to have our numbers come back up. But again, we've got to fund these positions. And so you may remember a number of years ago, maybe 6 years ago or so, we were typically budgeted, and I talk about these numbers all the time, about 40 or 41 officers, and we were down quite a bit. And so one particular year we had a surplus of about $1 million. And the following year, the board, and it was hard to argue, the mayor and the board said, look, we have some struggles. We've got to raise these tax dollars. The burden's on the taxpayer, and then the money's, and then we're not spending the money. And they had no problem with us not spending the money, but the fact is they had to raise the money in the first place. So they said, look, we'll fund, how many do you think you'll realistically fill? We'll fund those positions, and if you get there, we'll let you continue to process more candidates, and we'll find the money somewhere. And so we finally got to that, and that number was about 32. We had gotten there, and so I've been trying to get these positions back incrementally, and so we're to the point now where we're in a good spot, but we're not quite where we need to be yet, and so we're looking for additional positions, as I said, trying to get it back incrementally. And so a big part of our ability to fill these positions has been sort of the support of the board to provide sort of some interim measures to make the job more attractive, help recruit, help retain. And so they've done a lot for us over the last several years. This last contract we settled was a big part of why we're at where we're at. And so, but there were dollars associated with that, obviously. There were a lot of enhancements to the contract, but we've become a very attractive employer. It's a department that officers who work elsewhere are looking to come to, and that's what we've tried to do for quite a long time, and I think we're finally there. So, but again, the point is that to fund these positions, it takes some dollars. So that if you're so inclined, you're interested in kind of watching the process, come out December 10th and watch us at work. So that's kind of where we're at. Matt will talk a little bit more about what his outreach team is doing. So, they haven't been had a nice vehicle in a while to get out there, the street outreach team, but or the outreach care team. But pretty soon that'll be up and running. So, but a couple of vehicles that I mentioned to a number of meetings ago, we were able to leverage the opioid settlement money to fund a couple of vehicles, one for Matt specifically for the commander of the outreach team, and then one for the outreach care team. And so there was, the one was, actually I think they're both Fords, but one is almost done, the van, and then the other vehicle was a one that Matt was going to use, pickup truck, but that's been, we just heard I think yesterday that that'll be a little delayed now. But we had two vehicles. One was Matt's car, and it was uninspectable. We had two cars that were non-inspectable. One of the ones that Matt drove, but we were able to basically salvage some parts from, dismantle the one car, take parts off it, use those parts to sort of resurrect the other one, and with the using Stafford Tech, the students at Stafford Tech were able to salvage one of those vehicles and was able to be inspected. So Matt's got use of that car for at least another year, so Matt, enjoy it. But no, shout out to Stafford Tech because the students there, they do a great job. They're learning a lot, got great guidance from their instructors, and it was a great service to us, really. I can't tell you the money that we saved just by using them. Not why we did it, but they were able to get us in quickly and willing to do some work that other places might not have been willing to do. So shout out to the Stafford Tech. So with that, I'll pass it on. Thanks, everyone. Appreciate it.
Thank you so much, Chief. And next we'll have Commander Prouty with his remarks.
So I think the chief highlighted why we started the bike unit. Didn't have a car. We had a bike. I took him out for a stroll the other day. It started pouring. I felt so bad. That was bad, wasn't it, Chief? Yeah, that was, anyway. So the Situation Room at the Vision Center is complete, up and running. I'm going to be putting an email out and negotiating with probation and parole about moving the Situation table to the PD. The Community Care Network has been working out of, our street outreach has been working out of the Vision Center. It's great having them, of course, with Misha being added to the ranks. It gets a little loud, so I asked them to go do outreach out of the building. I think we've got one more coming, right, Angela? Next week. And watching the two organizations, Community Care Network, and then all of the folks and partners that they're affiliated with and work with regularly, and my CRSs, it's just pretty cool from our perspective. So great connection, and then we also have the OCT. So Dave is here, and you'll hear more from him and Candy. I went in the other day, and I'm like, what is going on in here? And they were making hygiene kits, and they were using the conference room to do so, and we had shampoo bottles everywhere and things like that. So pretty cool stuff happening. Very caring community. Love watching all these guys work together. And I think we're gonna, the next couple months, I'm excited to see what develops. Yeah, I'm looking at you. Misha's been pretty awesome, and she'll highlight some of her successes that she's had when they get up on stage. So, thank you.
Thank you, Commander. Now is an opportunity for any of you that have announcements to come on up to the mic, share them out, any events, local opportunities that you would like. Keep in mind our wonderful friends at PEG TV, they do post this on YouTube, so it's a great opportunity for you to be plugging any opportunities you want to share. So feel free, come on up, form a line. I'm seeing some folks already.
Hello, I'm going to stand up here so I'm as tall as Isha. We're the street outreach team. We are doing a Christmas wish list, and we're going to have drop-offs, like drop-off boxes. We have a list. I left some back there. Any, like even one item would be good, and it can be used. It's like blankets, tents, tarps, sleeping bags, hand warmers, boots, long johns, gloves, anything. Because when somebody walks up and I don't have the item, it's a little bit heartbreaking. So if anybody has any item used is great to donate, we have our numbers at the bottom. And it's extreme, it would be great. Thank you for standing with me.
Hi, Renee Beaupre-White with the Southwestern Vermont Council on Aging, and just to let you know that our helpline is in overdrive right now, so if folks are calling, just relay that we are getting back, but it might not be as quickly as people are wanting. Our annual meeting is going to be in Bennington on December 16th at the Bennington Museum, and all are welcome. And our holiday fundraiser is going on, so if anyone is looking to buy some really good chocolates for the holiday, you can access that on our website, and a percentage goes to the Council on Aging. Thank you.
it's still a big room with lots of people in it. So Diane from ARC, Rutland area, wanting to introduce Tia Polino. Many of you know her already. Tia's joined ARC as our program director.
Yeah, I'll just say hi to everybody. A lot of faces I've missed for a few months here, but what did they say about keeping the dog down? But I'm really thrilled to be joining Diane as the program director at ARC. It's a part-time position, but I'm looking forward to having a very fulfilling experience there and taking a few steps down from the ladder to really work with our community on more of an individual one-on-one basis, which I have really missed and really looking forward to. So season's greetings, everybody.
And if no other announcements are to be made, we're going to transition to our panel portion. Those are wonderful, and it's a reminder that the season is among us for lots of opportunities to give as well. So our panel, I'm going to ask that the panelists make their way up, and in addition to that, the room makes their way up. I promise that none of us bite. I can't speak for Prouty, but for the rest of us, we really don't, and it's nice to have an engaging group. We're trying to take this time and use it to the best of all of our ability, and we have a lot of knowledge here and we want to share it out, but we want to share it out beyond the networking time too. So this is your chance to learn a little bit more about what street outreach looks like in Rutland, specifically kind of Rutland City today. So if you have any questions, we would love to hear them. I think somebody accidentally snagged my questions, but that's okay. If you have a piece of paper with random questions on them, that's what that's related to, if you see it later. Oh, all right, Chief. You're on a list, and it's a tough time to be on a list. All right, so thank you for that. So we will be moving on to that. So as I welcome up our panelists, I'm welcoming the room to also come up and join us. Maybe in these first, let's try to fill the first 3 rows up. That would be really great. I know. I know. I greatly appreciate all of you. I see Eric moving a few others to the front. That's who said to come. All right, we will get this panel started. So we do have Adam going around. He has a microphone for when you guys in the audience have questions, so just raise your hand and Adam will be able to come along. So I know that that first question can be a little hard to ask, so I'm happy to be the first one to start it off. So for those that would like to answer, and just feel free to pass down the mic. First, let's make sure you know who's up there. So I'll have everybody start that's on the panel. I'll have you, Dave, start at the end with your name and your organization.
Hi, everyone. My name is Dave Carlson. I'm with the Rutland County Health Partners. I'm a retired substance abuse counselor, and my retirement lasted about 3 months, and I ended up at what used to be the free clinic. And with the team, I've been with the team since the very beginning, and I just refer to myself as the clipboard guy. So point of contact with most people. So that's...
Hi, I'm Sharon Decato, Community Health Team Nurse Case Manager at Rutland Regional Medical Center.
Hi everyone, I'm Morgan Blanchard, one of the social workers and behavioral health clinicians for Rutland Regional on the Community Health Improvement Team.
Hello, Kristen Keene, Care Coordinator, Community Health Improvement Team, Rutland Regional.
Hi, I'm Taylor Cohen. I'm a Community Resource Specialist with the Rutland City Police Department.
Misha Phillips, SUD Outreach and Engagement Specialist with Rutland Mental Health Services Community Care Network.
Hello, Angela French, Rutland Mental Health, Street Outreach. That about covers it.
I'll have you keep that mic right up there for you, and you may be the first to answer. Oh, she's getting it far away. So I would love to hear how all of you with a different variety of backgrounds and your organizations, how does your team approach outreach, and how does that differ from conventional clinical models of service? What makes you special? What makes you different?
Oh gosh, I'll start. As a team environment. We're really rooted at Rutland Regional. We're rooted where meeting people where they're at. So mentally, physically, emotionally, we have the opportunity of being able to work with community partners. So we can meet people in the field. We can meet people in offices. We can meet our patients or clients that we're serving in the community. We can meet them at partnership meetings. So that is a huge success for us. We don't have to be locked in completely just to the hospital. The approach that we use, I would say, is more of a patient-centered or person-centered approach. We want to be accessible to our patients that we're working with. We want to make sure that we're following their plan, not our plan. We typically talk about giving our patients a buffet of options. So that's what we're there for, to connect them to any resource that they want, but we're following their plan. So I think that's a little different. We're typically pretty reliable. We have a good community reputation, so we strive on that. What else do we need to add?
That one.
Okay.
Yeah, I think the first interaction is usually just kind of, like Morgan said, meeting people where they're at and just really listening to like what their need is and putting them at the center of whatever it is. We're not coming in with forms and saying this is what you have to do. We're like really listening and building that trust initially in those first few interactions.
Actually, we don't have a time limit on the amount of time that we can spend with clients, where some agencies have to make, short-term interactions. So if it takes 6 months, that's the amount of time that we spend with them until we get them stabilized and can hand them over to another agency that's going to follow them long-term.
So I think it's important to realize that there's a certain segment of this demographic that we serve that is completely incapable of functioning in standard clinical service delivery. They just can't. Take the filter of rational thinking and linear thought and problem solving and throw it out the window. It doesn't happen. So with our team and the core team, what we found is being as rogue as possible turns out to be actually the most effective way to reach people and to build those relationships. But that's who the team goes out and looks for, is the people who can't keep their appointments. They've had 7 burner phones, they don't have a phone number, they don't have an address, they haven't taken a shower in 3 weeks. Things aren't, they're trespassed from the emergency room, whatever the situation may be. So you have to really think out of the box and reach those people and try and create bridges for them to get services, and that's it. So.
Can I just clarify, though, if somebody's trespassed from the emergency room at the hospital, they can still access if they need care. That they just can't hang out in the cafeteria type thing, just to clarify that.
Dave, thank you. That was really well said. All right, so I wrote down a little note so I don't forget anything. So street outreach is about meeting people where they're at. They're basically in survival mode when they come to us, and the first step is connecting and building trust. And over the last 2 years, it's taken a lot, but it's definitely grown. And with Misha coming on, it's been much easier for her to connect because she knows people, but also having us as a team. And it's just basically reminding people that there is help even when they're at their lowest. And I feel like consistency is key. And we start with the immediate basic needs such as tents, tarps, sleeping bags, hand warmers, and blankets. I'm not pushing that as a sale either. And then we continue to build on those relationships. Once we do that, and we've developed one, we do work on referrals. We still follow them, but pretty much we're like the handoff, but it's supposedly was short-term and it never is. So.
To kind of touch base, so my portion of our team is the SUD, and it's about building those connections. What's really cool for me is I was homeless, I was addicted, I'm a person in long-term recovery, so I'm able to, when I am meeting people and they're getting to know me, they know that I didn't just read about this in a book, I've been there. I know those feelings and that hopelessness, and they get to see me on the other side that has gone through addiction and corrections and has gone, used to go through the back door of the police station and, into a facility, so they get to see that I used to be that person and this is me today, and that it is possible and I can help you get there. So that's been really the cool part of me being in the substance use piece of it. A lot of the people that are in the encampments I used to use with a long time ago, so that trust is already there, and then be building on that trust, it just opens doors that might not be available to clinicians if they were in an office. I'm in their tent, so it's really awesome.
Just to kind of close out this question, I don't want to repeat everything everyone else said because I think it's pretty consistent across the board. Something Commander Prouty says a lot that I think really sticks with what all of our missions is we're doing life with people, and it really is, sometimes it's just the human connection that gets the person to the next appointment. It's knowing that they have a team that'll meet them even if it's just to get to an appointment. They know that they can call or text. And I think that really summarizes our whole goal, is letting people know that there is a community behind them. It's so hard to do things alone. It's so overwhelming. I'm sure we've all been in the position where we're trying to make some change, and all of the information and all of the tasks we have to do to get there is daunting, and we rely on our peers and our friends to get there. And a lot of people that we're working with just don't have that. So I think what we do as a team, all of us together, is create a small community that person can rely on throughout until they create that stability. And then even after, we're still available if there's some hiccups.
Thank you so much, everybody. I'd like to open it up to the floor for any questions.
Can you hear me? Okay. So COVID has made us all pretty flexible in different ways, and especially when meeting with clients, like via Zoom, to make it more accessible for some people. But have you seen, specifically with outreach, how it has maybe impacted connecting with them negatively?
Well, I'll just say that everyone we've worked with has very little access to any electronics. Oftentimes, we're using our work phones to call on their behalf. Just recently, I put my phone number down for a bank so somebody could actually get a PIN number for his new card. They are changing phones constantly. Or getting them stolen, or losing them because they're having to leave encampments. I would say Zoom and electronic meetings is the most inaccessible for our most vulnerable population.
And we don't do that. We're right out there. But yeah.
I'd love to know if you can speak to the social, emotional, lasting effects of COVID, and if you've seen that in your work. Is that still being mentioned?
I think the whole homeless, I think the whole homeless situation we're in started with COVID. And then it just grew from there. People came in from other states and whatever with that. But that really was the basis of that. But with the COVID, as far as on the street, we're seeing a lot more than that. That isn't even discussed, COVID at all with us on the street, right? Yeah. We worry about other, stuff we could get, right? Yeah.
I think like in the substance use piece of it, there was a lot of isolation with COVID that we're still seeing today. With the isolation came a lot of relapse, a lot of, SUD, a lot of overdose, just a lot of use, and which isolates people even more. And now a lot of these people are displaced in encampments, which isolates them even more. So I think a lot of the social, mental, kind of situations we're seeing at this point, I do think it does stem from COVID. Isolation was brutal on people that had access to resources. So the people that didn't, and people that, really depended on those social pieces for connection, for recovery, did not get them. And there was a huge wave of relapse and overdose and all of that. And I think that's a lot of what we're still seeing today. There's a lot of barriers in place still today, 5 years later from COVID, and we're still trying to figure out how to maneuver through and get people through those barriers.
I would say one of the biggest pieces I've noticed is not particular with the clients that we're working with, it's more the community that they're residing in. I think COVID allowed us to shut our doors to our community and isolated us, and the outside became very scary. And the outside included those who were living outside, those who were different from us. It made us very, very homogenous. And we found, and some of the work we have to do is humanizing everyone else to each other again. Oftentimes we're having to remind people, this is a person who has likely gone through traumatic events, and if you're nice to them, they'll be nice to you back. This person doesn't want to be in this situation. They'll be kind to you. They're a great harmonica player. She's a great singer. She really cares about X, Y, and Z. And it's not the communities within the homeless population are stronger than I think the community of the housed and the employed are. I've found that we really are working with the community to reintegrate them into working with the community again.
Just wanted to add one other additional piece. We're seeing and continue to see the funding limitations that go with it. So I think it can be really a big toll on patients that we serve, where during COVID they had access to a lot more funding. And the funding instabilities has been a huge shift for people. So, they have the highs and the lows, unfortunately. So we do see that.
I was just going to add too, as far as like communication, that is the biggest gap that we are seeing that's been filled by the resource officers, in that these people don't have phones, or today they do and tomorrow they've lost it or it's been stolen. So how do we get them to that next appointment to get food or to a primary doctor and stuff? We can reach out to the resource officers or street outreach and say, hey, if you see them, this is the next appointment. And even the resource officers getting them to those appointments has been huge to fill those gaps.
So that kind of tells us how you collaborate and work together with one another. Is it possible to share a little bit more about what success looks like for you, and perhaps share some stories or situations that you feel were successful in your opinion?
Can we brag?
Please brag.
As an A team, this whole table here, there were a couple of gentlemen that have been long-term alcoholics and living on the street for years. Everybody had had their chance to interact with them and try to get them help and get them to residential stays, and they're back out on the street and drinking again, a month later. But with the situation table and this group and everybody at the situation table, connecting with these two gentlemen, they are now living in sober living situations long term.
Again, none of our successes are successes without each other. So when I bring these people up, I want you to understand that if the outreach care team didn't make the initial interaction and let them know that CRSs and other services were available, we would have never been able to create the rapport we did. Without street outreach bringing people and interacting with us, we would have never been able to have the successes. But just off the top of my head, there was a woman, long-term substance use. She had never been out of Rutland. She wanted to. She knew that being out of Rutland would be the key to her recovery. She got into a sobriety house. We drove her there right away. She is now in sober living with a job on her journey to recovery, and she's doing really well. We've had elderly folks who don't have the supports they need. We get involved, we get family in there. They are in nursing homes and they're in long-term living facilities. Those are our successes, finding stability and creating a safe place for them to continue living and continue being members of society. That's where we're finding successes. And I really want to emphasize that our success is built off of all of the tiny little pieces of Angela getting a blanket, us driving them to Brock, the hospital making sure that they have a primary care doctor, Dave and Candy making sure that they feel safe and that they have coffee in the morning, or they had a wound and Candy treated it. That's where our successes are, in letting them feel human again and then them being able to continue living in a stable.
So like, I've only been with community care for a month now, but you know, like Taylor was just talking about those connections that we have and us working so well together. My partner made interaction with somebody and was concerned about mental health, and you know, me being on the substance use, we were able to connect together, and it was a substance use thing. In a matter of 2 weeks, I was able to get this gentleman off the streets and into Divided Sky on a full scholarship, where he will be able to, you know, get the treatment that he needs. From there, they are, you know, ready to work on finding him sober housing, because how tough would that be, getting out of treatment, going back to a tent, you know? So being able to be a person in recovery and long-term recovery, I have connections where I'm able to, you know, I was able to get him into treatment. So, you know, giving that person a chance to start this journey and being able to follow up after. Just because he went to treatment on Monday and I was able to bring him and drop him off, when he gets back, I will still follow up and make sure that any supports, you know. So, like, how cool is that already? And so, you know, and that's what's really cool about us is, you know, she really focuses on the mental health, and I don't do mental health, I do substance. So we get to work together. Yeah, you know, and I'm learning all kinds of cool things from her and the rest of the team as a whole, and then again, vice versa. So, you know, I think that's what really makes the outreach care team and street outreach and what, you know, the hospital's doing and what everybody's doing so unique and so awesome, is that we all know what our specialty is, and that's what we do when we're out there, and then we get together and help support each other so that we can, you know, these are human beings out there, whether they're fighting whatever demon they have, you know, but they're still human beings, and it's our responsibility as human beings to make sure that they're okay.
One thing I was wondering about, I know that there are folks up here on this panel from a lot of different organizations and working within a lot of different systems collaboratively, and that makes the team very effective and able to sort of triage things in the way that you were just talking about. When I think about like working with multiple systems like these, a lot of these systems aren't necessarily designed to support a more novel approach like street outreach. As these things go, it's not new, but it's newer than a lot of the structures that we're all working within. I know someone mentioned funding earlier, and you talked about sort of community level obstacles. What like systems or structural obstacles do you encounter in your work on a regular basis? How do they impact it? And then what sort of things do you do to get around them and navigate that? Sort of a big question, so if you need to break it down.
So part of the reason community resource specialists exist is because there are these gaps where services want to fill all of them, but the structures themselves don't allow for it. Something I think we find predominantly is accessing medication when they don't have a ride or an ID. So we've used our IDs to help someone get life-altering medication. Transportation's a huge deal. Rutland City has a great, robust transportation system, but the minute they leave Rutland City, it's not as robust. So if somebody has a care facility or sobriety housing outside of the city, it's very hard for them to get there. So they call us, or the services that they're working with call us, we schedule it, we get them there. I would say that those are probably two of the biggest struggles. And then just meeting people where they're at. I think we say that a lot in social welfare, but what it actually looks like is very, very different on determining because of the structures. So for us, meeting someone where they're at, it actually means going to the encampment. What do you need? How do we get you there? And so I think those three things are the things that we focus on predominantly, but I'll let everyone else speak on what they do.
I just wanted to add, we do have a great bus system, but a lot of people we work with aren't allowed on the bus due to various reasons. So we do a lot of transportation, or they can't get a motel in Rutland, so they're like in Brattleboro or Montpelier that doesn't have a bus that goes directly there. You have to go from here to Middlebury to Burlington, back down. So there has been numerous times where we've driven them, or I have gotten somebody into a nursing home and driven them to Orleans, Vermont before. So yeah, I mean, we do a lot of that. And the encampment thing, it's been really nice having Taylor and Sequoia, because I use them a lot. Just I'm like, hey, we're working with this person, and if they're not there that day, I'll say I'll do it, and vice versa. So it's been really good.
So what I was going to say is, you know, traditionally, over the years in my position, I've seen services go to homes to provide that to people. Nowadays, that's not the norm. The norm is they're in a hotel or they're in an encampment. So there's gaps in services that they qualify for, but can't receive because of where they're at. And also staffing shortages with agencies not being able to meet the needs of what's happening with our aging population in Rutland.
I'll try to sum up the rest. What we see a little bit in the field is releases, and I think that's more like a systematic, but it does really affect the community side. We don't have like a general release, and I think it's probably more on the legality side, but when, unless you're like a seasoned social worker or care manager or clinician or whatever it is, you have to learn through that process through kind of frustration for our patients, but there is no such thing as like a general release. Each agency has their own release, but if you're working with somebody that has various needs, let's say, they want to apply for 3 Squares or Reach Up or Social Security, or they want to talk to Brock or Homeless Prevention Center or housing agencies or all of the above, or even Rutland Regional Medical Center. They want to apply to a community health center. Every single agency has their own release, and again, you have to be a seasoned social worker or clinician or caseworker or care manager or whatever it is to know that you're going to need the patient or person that you're serving to sign each and every one of those needs. If you don't, and you're serving these populations that we're working with, and you're meeting with them for the first time, unfortunately what will happen if you don't have all those releases is you're going to be blocked or barriers, and you're trying to support somebody in a very quick time frame, and you won't get very far unless you have all of those releases signed. So that is a big thing that we face barriers on. Hopefully you know what you're doing when you're meeting with somebody, but if you don't, that's a problem. And what we do to try to support our patients to ensure that they are getting the best care is through care coordination. So we'll meet with everybody like on our teams. We do that regularly when we're supporting somebody. We do it even a step further now with the situation table to go over outline what a patient's goals are, what their needs are, and what the roles are, and who can basically establish what to make sure that you're prepared ahead of time. So hopefully that answered your question. If there's anything else, let us know.
Just to add on to what Morgan said, CRSs do not have to follow HIPAA. We follow a criminal justice expectation. So oftentimes we will be working with somebody and they say, oh, I'm working with Morgan, or I'm working with Angela, or I'm working with somebody in a service. But we often know those services, so we become a one-way information system. We will let the service know, hey, I just spoke with X, Y, and Z. You don't even have to confirm that this is your client. I'm just telling you that they said this is what their needs are. They don't even have to acknowledge that I told them it. But we often find that that's our way around this very complex way of somebody who has acute needs is interacting with almost every service in the city, and CRSs are able to go to every service and just let them know what's going on and keep them up to date, which is not something every service can do.
Good afternoon. Most of you I've worked with in the past, I can remember in our community when the word outreach was not a word, and you've come a long way. Taylor, Morgan, Sharon. I want to commend you for the work you are doing. Thank you for doing the panel. I think it's vital for our community. Collaboration, I heard that word. We worked on that a lot back when I was doing outreach for the veterans. Treating them like they're human, making our clients know that they are cared about, I think is the most part of our compassion for the work that you all do up there. So I just wanted to say thank you. You're doing a great job. I'm glad you're all at it. You're the right people for the right job. Thank you.
Hi, you've mentioned situation table. And could you talk just briefly how what you do differs from situation table, or how it complements it? Because we hear outreach care team and situation table, so just distinguish the two for us if you could.
So the situation table is a tool. It's not something that overrides our outreach. In fact, it very much relies on the outreach. So there's 4 filters to the situation table. Filter 1 is meeting the person and seeing the acute level need. So I interact with John Doe. John Doe I interact with, he has over 3 acute needs that are all in different service areas. That is my recognition, and I bring him to the table. The table is a place where I can gather all the services this individual does not have, and we create a team. That team is comprised of outreach mostly, and then we will go out together and we'll have an email chain. This is with consent. And we will do a 24 to 48 hour response. In that 24 to 48 hour response, we introduce them to all of the services that are accessible to them. We already have a team that is now aware of their needs, and it's a much quicker process. Essentially, it just builds off of our outreach and makes it a much more succinct system for us. Would you guys agree?
When I started this a little over 2 years ago, the street outreach program didn't exist, my end of it. And what I did was go out with the people and then do referrals to these agencies. So it has really helped to get them all in one room, because it was what I was already doing, but I had a lot of obstacles to do that. So it's been very helpful.
Just to answer the rest of your question, the major difference is situation table is about elevated risk, and so it's about helping to get an individual or family out of an acute elevated risk in a short period of time. And most of our work outside of situation table continues for much longer than, let's say, 2, 3, 4 days. So I think that would be the main difference between the situation table and what we continue to do.
So I think one of the things we've talked about a lot is collaboration, caring for the people that you're working with and stuff like that. I want to know, and I think it's really important for other organizations to know, that big question of trust. How do you what are the tools and what are the things that you do to build that trust so that people will then trust you to do the work? And how does that sort of look? And is there any tips or tricks that you all have found out with your efforts that could help other organizations that might be interested in doing more outreach?
Can I do first? I think for myself and our team, and the community health team, is that if you show up every day for these clients when they call and they have needs, that's a big thing to build that trust. They know that they're going to get a response, and they don't have to wait a week to hear that response or not get one at all. sometimes from different agencies, which is unfortunate, but that again speaks to the, not having those positions filled to some extent. But that's something that we work very hard at, is being there and answering their needs when they have them. And I think that builds the trust mostly.
Yeah, and just to echo that, just walking through the journey with them, like not just handing things to them, like, sitting with them in their experience, and just letting them know that we're there for them, and we're going to get through this together and walk through it with you together. And yeah, I just wanted to add.
I think it's a lot of consistency, just showing up every single time, and that's been the biggest thing, is just being there, showing up. A lot of my outreach is through the Methodist Church, and just even smiling. And some days that's all it takes, is I'll just smile at somebody, and it just makes them feel better, and they'll approach me. And I don't. One of my big things too is the big part of the trust is I don't push what I think they should be doing. I ask them what they want, and then that's what I support, and I don't push any other agenda. It's because it's not my journey, and people know that. And so when somebody asks, and I treat them like they're human, like I get them a shower,
Which is huge.
it's huge. You don't even understand how a shower can change a person's entire day. And when you haven't had one in 3 months, clean clothes can change a whole person's day. And again, hugging, and I had it today, somebody hugged me, and and I hug them. I don't care where you just came from or where you're headed or what's going on in this moment. That person needed that hug and that smile. So, just building those connections and just treating people like they're human has built the bridges. People are engaging more than they would have prior to that.
So kindness and compassion go a really long way, and I think having them just feel like you're listening and seeing that you're there for them, and then doing it over and over. Like, I can give an example. I have been around this one individual. I work really well with grumpy old men. I don't, but I mean, he wouldn't even say hi, really. And I just kept at it and kept at it. And then finally, now we're getting grins, and then asking for support around Social Security and helping the call. And that is huge, because it's taken 2 years to have that happen. And it's just being there, like everybody has said, and treating them like they're human. And the hug thing, they'll hug you and then be like, I'm sorry, I haven't showered in a month. And it's like, it is what it is.
So I want to second everything that everyone else said, and I think it's especially important, especially since we have Castleton interns here, that honesty and acceptance is some of the biggest aspects of gaining trust. I am always honest about what I can and cannot do, and I will be very open. I can't do X, Y, and Z, but I will sit here with you while we try to figure out who can. I will find the people who will do all of these things, and we'll work through it together. And also acceptance and social welfare. We talk a lot about autonomy and right of risk. People are allowed to make mistakes. They're allowed to fail. They're allowed to make bad choices. And ultimately, it's our job to stay there and be okay that this person chose every wrong choice and is now in a worse place because of it. But at the end of the day, I'm still available. I'm still here for them. And I find that that's the biggest key to letting them know it doesn't matter that they make these choices. It doesn't matter that they've chosen wrong, in my opinion. They made those choices, and that's human. And I'm still here to help them make a better choice when they're ready for it. And I've found the biggest change in that.
I have one more thing that you just made me think of. Well, two. So when she says showers, I just want to say it's a collaboration with Project Vision. We would not be able to offer that and laundry without them. We grab the key every Friday now. We have it set up, and we have to pick a few. Otherwise it's like 7 hours, so we pick a few. I also wanted to say no judgment. They know we do not judge, because if we did, we wouldn't be in this position, and that really goes a long way.
I just wanted to say that, there's a whole spectrum of support represented up here. And I am at the very, very point of inception for a lot of people. And you talk about the barriers and the things that you have to surmount to reach people. Many, many times, I can't even get someone to give me their name when I'm about to try and give them something, or they give me a different name week after week. Or we had a guy who fell into a campfire and had horrible burns on his hands, and he just wasn't gonna tell anybody anything about it while we waited for an ambulance and things. So it should just speak to the amazingness of the fact that people can go from that point where they are they need help, they're pushing you away, to the acceptance that people begin to get and work in. So it's not, again, you throw the rational thought piece out the window. You're people that are without realizing it, probably really working against themselves and making it difficult to reach or to, even get into a system or to get help in any way. So, I mean, it boggles I sit at the back of my truck, handing people, that's the point of contact for almost everybody. And last week alone, again, somebody would not tell me his name. And it's usually a new person, sometimes a transient person, but again, showing up enough and being there and not being that judgmental about it. I stumbled across people in the brush under the River Street Bridge with, in the act of shooting up, drawing blood in and out of their vein, and the whole, it just, so it's very hard to get that person's name when you walk in on them in the middle of that act. But yeah, I don't know, it just, I don't know, but that's.
And I guess one other thing that I can add from our team anyways is, again, saying, meeting them where they're at, handing them a package of forms to fill out or to figure out themselves, 95% of the time doesn't work. They're just gonna throw it away or just sit there and say, I don't even know where to start. So if you can sit with them and do that kind of thing, that's gonna build a huge amount of trust with them. And that's the support that they need at that moment.
CHT, here we joke about, they never lose our number, ever. And actually, I'm really proud of that as care coordinator, our team, and everyone else I'm sure can feel the same way, but I'm proud that they actually go out of their way to find a phone to call us or reach out to us, which means that we did our job, and I could not be more proud of that, and I'm thankful to be in this position to be able to help as many people as we can.
We have time for one more question. Feel free to ask it, yeah.
What are the most common needs you're seeing right now, and especially with the seasons changing?
Most common needs?
Yeah, that you're seeing need to be filled in the community.
Yeah. Housing remains probably number one. We have a limited access to mental health and getting in to see providers. I think Vermont is working on that. We have limited access to food. Vermont is incredibly resource friendly, so I do want to hit the positive that we always talk about how Vermont is resource friendly in comparison to our sister states, but housing, I think, remains number one. In lieu of that would be getting access to mental health or even substance use. I think following would be long-term care facilities. We do support our adult and aging population, and it is incredibly hard to get our populations that are aging and need a long-term care facility to get anybody into one at this point in time. They're very limited in Vermont. So we are relying on our other states to try to help us and encouraging hopefully more beds here in Vermont. So hopefully that answers that. Anybody else? Yeah. I know there's way more than that, but those are our top.
I do want to say just Rutland Mental Health does have something called open access now, and they can walk in and they get an intake and an assessment, and then they'll get an appointment. After that, we sometimes are the help to follow up to get them to there, but we do offer that Monday through Friday, 8 to 4. Just wanted to get that out there. So that's for mental health and also IOP and SUD.
So housing is a huge one. medical care, mental health, huge. It's not necessarily that the resources aren't here. Again, we're very resource friendly. That's why so many people come to Rutland. I think if you look it up, we're one of the best places to get resources. The issue is, I think, when you are actively in substance use, when you're actively in psychosis, actively dealing with a mental health issue, you kind of need your hand held through the system. The services are very daunting. The paperwork is very scary. I don't have my birth certificate. I don't know all the information. I don't have my Social Security memorized. So I can't even think how hard it is for somebody who can't remember the last week would go through all of these services and navigating every system, having to sign every release of information, having to remember every doctor, every physician, every specialist, every mental health person you talk to. All of our services are wonderful and they want to be more cohesive. It's just because of the systems and structures in place, it's very not person friendly. And so I think something that we all work on up here, and even our secondary agencies that we work with, especially at the situation table, every service that me and Sequoia are interacting with, we have points of contact that can help us walk people through. But the issue is that's usually one person at a time, and I think the resource that's really needed is somebody to help walk people through, which is why I really, really like our peer supports. We just got one in the court system, which I'm excited about, and they're continuing to expand. Turning Point has a lot of peer supports. I think that is a big resource that we need to rely on a little bit heavier because the systems are just very complicated. We have them. It's just so daunting and overwhelming.
Great. Well, thank you so much to our wonderful panelists and all of your information. We really appreciate your time, and we typically end on a positive story, but I think that that positive story is in front of us and the work that they're doing and sharing, and all of you in this room who are then connecting with them and continuing it. So please go enjoy some wonderful pizza given to us by Domino's, as always, and continue to network and collaborate with these wonderful folks. We'll see you next month.